Thank you for coming. We wanted to kind of showcase some of the software applications that we use to process the CT data that we've been talking about, kind of in a different way. This is the post-processing that occurs to take a look at the sort of the 3D lab that's done to take a look at the coronary arteries before some of the applications that you saw earlier with FFR and things like that. So this is part of the machine learning that we apply to the software, or the software applies to the acquired CT data. And this is Circle software, and the benefit here is that Circle is been in this space for a long time and well known for its post-processing and accuracy with cardiac MRI. So this is kind of a movement into both of the advanced cardiovascular imaging spaces where we now have an application that can be applied to cardiac MRI and cardiac CT. And the advantage here, as well as Circle is very well known for its quantifications or accuracy with the cardiac MRI structure and volumes. So on cardiac MRI, and that's what they are, is Circle. We used to have to, in the early days, this is rolling back to 2007, draw our own circles on each cardiac MRI. And what you would do is you would do circles in end diastole and end systole using a Simpson's equation and do all your own circles and get your function with EF volumes and stroke volumes and things like that. And then some of the data that was acquired in time, instead of each person drawing the circles, Circle software is able to auto-process that whole thing so that in seconds you get all that data, and again it gets into the reproducibility that's available with these applications where the inter-user agreement and in between different physicians' agreement, it's automated, so all of it is very agreeable in between all of those applications. So they take a lot of that history and move it into the cardiac CT space where, again, we use those applications, especially with the function and also some of the, what you saw earlier if you were in here, the curved planar reformat imaging. And all of that is now able to be done within single or 2 clicks, and you get all of that information. So we'll do a short introduction again.
Hi, Sean Almeida, cardiology.
And James Thompson, radiologist, University of South Florida. And I was doing that because this is my medical student that we brought from University of Central Florida. Go ahead and introduce yourself.
Hello, my name is Patrick Malazzo, and I'm a medical student at UCF in Orlando.
So we're going to sort of show that easeability with the applications and being able to post-process the CT software. So Patrick is going to go back behind the scenes, and I'll kind of walk through how these post-processing is done with automation. So here we have a CT acquisition, and again you can see the different phases that are in the study. Usually we'll get typically we'll get a calcium score, and then we'll also get the contrast enhanced CT portion. And what we like to see is the multiplanar reformat. However, you also go in next and you can take a look at the curved planar reformations that are available. So 1 click and you see how quickly the center line is drawn. So the green line is tracking the high attenuation contrast throughout a linear acquisition or a linear area of interest down the coronary artery. And what it does is it manipulates the data around that linear area of interest. So you get a nice layout of the coronary artery in its complete volume, which you can't do unless you do the post-processing. And again, this in the early days is a very tricky process to do, or with applications in machine learning. Those curved planars that we got often had to be remanipulated because it's the computer tracking a center line down an area of attenuation difference. And often you didn't know if the line was mislining and getting along the outside of the vessel, and you would get curved planars and not really know if it was an actual stenosis or some kind of artifact with the vessel. But you can see there's no need for retracking. You can just quickly, with one click, get what you would almost need a separate 3D post-processing group to do for you in your workflow. And then we can see they're able to go down and start picking up some of that pericoronary fat attenuation or inflammation around the vessel. And what's nice here is you get all the things that you would need from normally through a 3D lab for one, evaluation of the cardiac exam, but also for reimbursement. So a lot of these things are also, whether it's the 3D tree, whether it's the curved planar of reformations, and then the actual evaluation of the cardiac examination. Patrick, do we have a calcium score we can also look at? So this is another part of it, is the calcium score that you can see is all automatically done and tracked. Again, this is contrasted with most other software. Still, you need to involve yourself with a semi-automation process. So this is all automatically regionalized, and the area of interest are already automatically placed into whether the calcium is in the LAD, the left circumflex, the RCA, whereas most others you'll have to go in and whether they call it lassoing or going around the area of interest and actually setting the computer to the area that you have of interest where it's the LAD, and that's what you want quantified. So the quickness and the accuracy with which this is doing this is all 1- and 2-click applications. And why don't you go down and just show, Patrick, the difference that we see, how nicely it kind of correlates. So you have the left main coming off, and then the yellow is all in the LAD, and it nicely tracks it from, and go down, all throughout the vessel, as well as it looks like a little bit of a trifurcation, and then down through the RCA. And this is where sometimes people ask me about this. If you go back up, Patrick, you can see calcium, all of these densities are put into voxels. So there's some brightness that you may see here, but it remains below the quantitative algorithm which calcium score is being done. So it's picking up only the threshold that the Agassiz score is quantified for. So you can see this guy has calcium score of 554, or Agassiz score 675. So that's high. That's what we were talking about earlier, the different stratifications of the calcium. So it does all of that calcium scoring, and it does the post-processing for the coronaries, but we also have everything in a complete package where we can do all of the cardiac CT work, besides even just the coronaries. We can do structural work. So can we see an example of the TAVR? A lot of people ask us about the TAVR is a 2-click application. So again, the most important thing with TAVR is you're really trying to quantify that LV outflow track with high accuracy. So we can see here how quickly it goes and gives you all of your measurements that you need for your TAVR. So you see how often, and this is a lot of times, contrasted with echocardiography, which in the LV outflow tract, and that's why the CT becomes more accurate with its measurements, is echocardiography puts some assumptions in for its quantification because of the just differences in the imaging technique. So in echocardiography, it's assumed that that outflow tract is a circle, and it's quantified through that assumption, whereas we can tell pretty clearly that it's not. It's very individualized. It's usually an oval shape. However, everybody's outflow tract is a little bit different. I consider it like somebody's neck, where it can be turned or a little bit thicker or a little bit kinked. But this, you can see, comes in and measures it very accurately and puts in all of that data into the report for you. And then we have MRI, right? This is all one seamless system. So as you move into or can process an advanced imaging lab, you can do both coronary CTA or cardiac CTA and all the structural work, as well as the MRI. And Patrick, can we go back to the curved planar reformats? And one of the things we wanted to open up with this kind of environment is to demystify a little bit or open up the images that are obtained, because there is a lot of, and we talked about it earlier, value for patients to be seeing these type of images, especially the curved planar stuff, and for primary care to have the ability or control to be able to show these types of images and know the terms or the lexicon to communicate those. So we're working with the SCCT as well to kind of bring in that kind of a collaboration where primary care is able to have an understanding, just like they do with the lab work. You get back lab work of blood work and cholesterol, but these types of images are easily accessible, and being able to see the coronary arteries or small pipes is very meaningful to being able to communicate, and not only communicate with your patients, but with the radiologist or cardiology imager of what kind of data is coming off of the actual scanned exam. This kind of application, or circle cardiovascular imaging, is transforming cardiac care. They also see value in this space where cardiac imaging is not only, with the changing guidelines, becoming a frontline test for, or the first test for cardiovascular disease, but that its application into or out of the cardiology specialist area and into primary care. So the role of cardiac CT and advanced post-processing software is very helpful in being able to spread this or open it up when vendors and come in and help us with being able to expand this into the future. Again, you saw how quick and highly accurate these detailed 3D images of the coronary arteries can be seen, and within minutes. And kind of demystifying that so that we can see that primary care can control some of this information as well. And the early detection and early intervention, we can identify this risk before any cardiac event occurs and lower the healthcare costs. So we reduce the need for other unnecessary or invasive tests. And we talked about that before. So this is the power of preventative cardiac CT, detecting the silent threats. Many cardiac events, again, occur with no symptoms. And we get into this personalized risk assessment, not just within cardiac CTA, but also within the vendors and the applications. And that's changing the standard of care, moving to a more reactive and proactive cardiovascular health management. The role of post-processing the cardiac software is enhanced image clarity and precision, and this AI-powered analysis for accurate plaque detection and calcium scoring, automated workflows, like you saw, where normally a whole 3D lab would have to post-process that, reduces the interpretation time for radiologists, cardiologists, and I would also say to lend evaluation into the primary care field. Advanced functional analysis, you provide deep insights into the heart function, perfusion, and plaque morphology, and improved diagnosis and treatment planning. Enables physicians to create more effective and personalized treatment plans. And the real-world impact. Studies show that the preventative cardiac CT scans have reduced heart attack rates by identifying at-risk patients, and patients with no symptoms but significant plaque buildup can receive treatment before the heart attack occurs. And hospital and clinics benefit, faster, more accurate diagnosis, lead to better patient outcomes, and reduce hospital admissions. And empowering patients through the visualization.
Yeah, so I
Tap on
think
that.
for this group, if you're not a cardiac imager or radiologist, the value proposition here is that a picture really speaks 1,000 words. It's one thing to describe disease to patients who this is new information, this is hard for them to comprehend, grasp, come to terms with, and accept the therapies that you want to implement. And I think the real value proposition is you can utilize software like this in your practice without really a lot of add-on tech, right? Just you can do it on your laptop, on your office computer, what have you, to help them visualize disease. And I think there's a couple ways that I would foresee you implementing something like Circle in your practice. Number one, so that you can look at the images yourself. Does this look right? Does this make sense? There's some pitfalls with coronary calcium scoring even, where if you're having a technologist do the scoring, as some sites do, what if they mistakenly circle aortic valve calcification? What if they mistakenly circle mitochondrial calcification? This allows you to directly visualize, especially if you're seeing numbers that may not make sense, right? So, and you can show the patient, and I do that for every single patient that comes to my practice. I show them the coronary calcium score, because in doing so, and Budov has shown this, you increase the patient's ability to not only make the lifestyle medication, but stay adherent to some of the therapy decisions that you're going to make. And then same with the coronary CT. I mean, to me, CT, unlike MRI, unlike echo, I mean, I read all these things, but CT is like one of those, old school point-and-shoot disposable cameras. It's easy modality to pick up and learn, and I wouldn't let the software become too intimidating. It's actually very easy to work with, especially with the AI tech that Circle is integrated. So there's a really strong role for showing patients, and you yourself visualizing this. Seeing is understanding, so when patients can visualize disease, see the plaque, see the hard stuff that you're pointing out, they're more likely to be adherent to therapies, increase compliance. It can really change that conversation to, look, I don't want to take a statin, my best friend took a statin and now they have diabetes, or so-and-so took a statin and now they have dementia, right? Like there's all sorts of misconceptions out there, and you can use imaging as a tool to help better convey your messaging. It definitely helps to reduce fear and encourages action because they're directly visualizing disease. It gives them a sense of control. And then obviously, as you've heard about all day today, CT for reducing future cardiac events. It's the only imaging modality where in several studies, the primary outcome measure is not diagnostic accuracy. The primary outcome measure is reducing MACE events. Show me a stress test that uses that as a primary outcome measure. So I think using a circle as a vehicle for showing those images, helping patients understand, because showing a raw DICOM image off of a PACS system is not very intuitive.
Yeah, and I think it can't be overstated. Like, you see how quickly these applications now allow you access into this information. And even with patient compliance, we always know that the, medical treatment, their compliance with is very low. It's hard to put a patient on a drug and keep them on it consistently. However, if you show a patient, and it's easily understandable to most anybody, these are little tubes, they're little pipes, and when somebody sees their pipe narrowed, it makes a strong impact immediately to both their future compliance, but also for understanding and resonating with the primary care physician they're talking to. If you can speak this same language to them, where they see the images and they know that you know the images and are involved in them and how easy it is to do, that's a significant thing to the relationship.
I think there's also, it can't be understated, and curious what you all experience is when you refer to your friendly local cardiologist, this allows you to kind of speak the same language, especially if you're correlating across different images like a stress or CTA or a CTA and a cath. It allows you to be able to directly understand and use some of that same lingo. So I think that is really important to be able to visualize the images your own. And in fact, Circle has provided, if you look on your tables, this, a free software opportunity so you can, and that's whoever's here can access it, and all you have to do is have your system send images there and you'll be able to directly visualize. So it's a really nice opportunity to kind of play and figure out the buttonology because it does have a lot of power. It's a very powerful tool clinically.
Patrick, can you put that up again and kind of show? I think that's some of the most powerful stuff is being able to see how easily to...
And show the function.
Yeah, do we have some of the function as well? Circle's been in this space for such a long time and has gotten so well at the data through the gold standard, which is MRI. And the reason the MRI is so accurate with this stuff is CT's great, right? But what you're seeing here or noticing a little bit is the temporal resolution, which is just the amount of time you can acquire the images. This is a little bit slower where MRI has a higher temporal resolution and you feel or you notice that you're getting the entire or the accurate end diastolic measurements. And here, right, you get all the EF, all the stroke volumes right away, and right away it comes up with the standard projections that are at least we're familiar with, the 2-chamber, 3-chamber, and then the short axis in the upper right.